The Center for the Improvement of Human Functioning International presents this luncheon lecture. Today's topic, controversy. Do antioxidants help or hinder chemotherapy and radiation? Your presenter, Glen Hyland, MD.
By way of introduction of our speaker, I wanted to tell you a little story that happened back in 1820 on the steps of the Salem Courthouse in Salem, Massachusetts. Does anyone know what happened there then? Dr. Jackson, you gave away my story. Colonel Robert Gibbon Johnson was there on the steps, and there were 2,000 spectators there to watch him die. And the reason that they thought he was going to die is he had with him, now I've just got these little tomatoes, but he had a basket of full ripe tomatoes, and he was going to eat the entire basket of tomatoes. And back then, everyone knew, of course, that tomatoes were from the deadly nightshade family, and people who ate tomatoes died. And so they were all there to just watch him die. And much to their surprise, he ate the whole basket of tomatoes, and guess what? Thanks to him, we now have a thriving pasta, taco, pizza type thing, and where we can enjoy that because he was courageous enough to change that thinking, to change that myth understanding. So today I would like to introduce a special guest. Dr. Glen Hyland has been coming to the center now for about a year, 1 week a month, and it's our privilege to have him address this topic of looking at how antioxidants, do they hinder or are they actually helpful in chemotherapy and radiation therapy? Dr. Hyland comes to us with 20 years of experience as a board-certified radiation oncologist. He's an excellent clinician, a fine scientist, and just a very wonderful man. So, Glen, welcome. Thank you.
Well, I'd like to welcome you all here to the Olive Garvey Center for Healing Arts, the Center for Improvement of Human Functioning International, and the Biocommunications Research Institute. We believe that this truly is a bright spot for health. Before I start, though, I would sincerely like to thank people that at the last minute got these slides together for me. Patty Jopes, Bill Chambers, Dean Dodson, Paul Taylor, and Jan Austin. Thank you so much. I was tardy in getting my material here. Today's topic, controversy, antioxidants, cancer, chemotherapy, and radiation. This will be an introduction. It's a controversy that has existed for the 32 plus years that this institution has been in place. Our founder, Huey Reardon, was passionate about this controversy. His clinical investigations supported the concepts that antioxidants could delay aging process as well as help prevent chronic sustained illness, cancer being one of those. He also was a firm believer that, and found out from investigations, checking for vitamins, minerals, amino acids, and so forth, on the patients that came here with cancer, that the majority of them were low on antioxidants, especially vitamin C. Conservatively stated by Dr. Patrick Quillen, a PhD nutritionist previously with Cancer Treatment Centers of America, 40% of cancer patients are malnourished at the time they are diagnosed, and 60 to 80% of them are malnourished by the time they complete standard therapies. Dr. Reardon also believed in combining high-dose antioxidants, not just using vitamin C, but to use others along with it. And his 25 years of experience, he has a paper on that was recently published. But here he shows that patient symptoms, 80% of the time, were decreased. That overall survival was commonly prolonged, 2 to 4 times that compared to historical controls. And that occasionally they would see patients with complete responses occurring within just a few days. These kinds of results were also seen by Abram Hoffer and Ewan Cameron, Linus Pauling, and gave further credit to the fact that these antioxidants have good anti-tumor activity. Combining therapeutic doses of antioxidants with standard therapy has been shown in many studies to improve the response while also being able to decrease the side effects. And we'll go into this more in just a bit. At this center, we have tended to use very high-dose antioxidants, giving intravenous vitamin C, also supplemented with oral vitamin C and other antioxidants, and we get a better result with those than using just one alone. We use the orthomolecular approach here, where we test patients for all their vitamin, mineral, amino acid levels, and we try to set up an individually based diet that will truly help replace their nutritional needs. This certainly is an approach that Dr. Roger Williams has suggested and is one of the major philosophies of this institution. During the time of looking at this, Dr. Reardon was looking at antioxidants as a means of decreasing decreasing the side effects of standard therapies, but he was convinced that there were other mechanisms involved other than the antioxidant or free radical scavenging of these antioxidants. And more recently, Dr. Mark Levine at the National Institutes of Health has shown that there are other mechanisms by which antioxidants work. And in this particular article, he referred to vitamin C being able to increase hydrogen peroxide in cancer tissue, and that was a method for inducing cancer cell death while normal cells were being protected. So here we have an episode of where antioxidants work as pro-oxidants in cancer tissue. Some believe because of lower oxygen saturation. Others have found that because the cancer cells have increased number of receptors for glucose type receptors, and vitamin C tends to follow those and go through those receptors into the cancer cell. And this correlates with what Patrick Cullen, who has been with the Cancer Treatment Centers of America, was also saying. Antioxidants work differently in normal tissue than in cancer tissue. They're protective in normal tissue, and they tend to treat the cancer tissue. Another thing that happens is antioxidants can also stimulate the immune system. They've been shown to increase the number, activity, and migration of natural killer cells, and also increase blood counts of bone marrow that has been suppressed. And other work has shown that antioxidants also help stimulate the tumor suppressive genes. These are the ones that turn off fast cell cycling and allow for improved cell differentiating. In other words, allowing a time for normal cancer cells to revert back into to normal cells. And if that can't be done, also to help stimulate programmed cell death called apoptosis. Why is it then that there has been so much controversy over using antioxidants with chemotherapy or radiation? To give a background to tie this to, I'd like to cover a few other things along with this, and that's free radical theory by Dr. Harmon, how cancer arises, some concepts of cell cycling, and then put that together with how chemotherapy works, how radiation works, and why they, most of the time, will work synergistically. My comments will be based on articles that have gained most attention by the public. There are literally thousands of articles that are out there. If you look at the tissue research, in animal research, and human research, one estimate was that there's over 7,000 articles. It's very difficult to get your arms wrapped around that kind of a field of knowledge. After that, I will follow this with a short case presentation of a stage 3 breast cancer patient and discuss recommended treatment options. And then I will make a biased summary and some further recommendations. As you can see, well, I don't have these slides, but the free radical theory of aging started with Dean Harmon. And he proposed in 1954 that free radicals produced in the body might be the cause of aging and disease. This was truly a radical thought because Previously, it was thought that aging and disease were determined by our genes and that they could not be messed with, that we were predetermined for the path that we're on for developing illness. Well, where do free radicals come from? They come from within us. Food that we take in is changed, and the free radicals are formed in the process of making energy molecules for our body. That's primarily in the mitochondria, but also in making proteins. There are some free radicals released in the endoplasmic reticulum. But the body makes some antioxidants to help support the free radicals, to help prevent them from causing tissue damage. And these are glutathione, and some of the exogenous ones that we see are mostly from our meals, and I'll show you those in just a minute here. The thing is, the presence of free radicals not only come from our body, but they come from stresses from the outside, whether it be environmental stress, which is the most common, psychological stress. Those are converted metabolically, actually, in what will appear as free radicals within our body. Dr. Bruce Ames at Berkeley University suggests that each cell in our body has up to 10,000 hits by free radicals per day. So the chance for membrane disruption and for DNA damage is quite high, but we do have very good protective systems if they are in place, and if those protective systems are allowed adequate antioxidant replacement. When we get into trouble, free radicals, if they're not balanced by antioxidants, if they cause organ tissue damage, that is what we get with aging. If they cause damage to DNA, that can lead to cancer initiation. And if we get the free radical immune system alterations, that's where we get autoimmune disease and other chronic sustained illnesses. And then just one other thing about the basics. Free radical is a molecule that has an unpaired electron, so it can react to other tissues. Oxidation is simply the loss of the electrons from that atom or molecule. Reduction is the gain of electrons. Antioxidant is a chemical or substance that inhibits oxidation, and a molecule that quenches free radicals and prevents injury. So here is, just to give you an idea of what our food supplies to us, these are the exogenous things that we get from our diet. Vitamins A, C, and E have antioxidant activity, beta-carotene also, and carotenoids. And even though there's over 1,000 types of carotenoids, the beta-carotene, lutein, and lycopene are the most active. Bioflavonoids, it's a family of over 5,000 substances, and these work synergistically with the vitamins C and E and help potentiate the actions of the other antioxidants. We can get these from grapeseed extract, peanut skins, and maritime pine bark. Two major classes also, sometimes minerals can serve as antioxidants. Selenium regenerates vitamin E, and in that process serves as an antioxidant. Isoflavones from soy products, and the polyphenols, which are mainly our green tea with epicachin products, molecules present there. And some herbs like ginkgo biloba, or plants of medicinal values like curcumin, quercetin, clack in beans, and fortunately also dark chocolate. So the antioxidants made inside of us, ones related to amino acids, are the lipoic acid, glutathione, and coenzyme Q10, enzymes such as catalase, which breaks down the hydrogen peroxide, and hormones like melatonin. And I'll try to show you as we go where these are active. Okay, I think we can see. So what we have is, from this, we have chemical exposures from the outside. Foods that we take in also then will, in the process of making energy, will create these free radicals. And we can go from, as far as the process of carcinogenesis, we get an initiated cell, a pre-neoplastic or pre-cancer cell, and then if more mutations occur, we can develop cancer. So in normal tissue growth and replacement, proliferation is controlled. And old cells die by apoptosis, programmed cell death. And this is important because we have to replace those with new functioning cells. And if we didn't have that process of apoptosis, our organs would continue to grow in size as we grew in age. So apoptosis, being the programmed cell death, is also initiated by free radicals. And this is where some of the controversy occurs, is because people like Dr. Selagnik would say that we have to have free radicals present, should not use antioxidants, because that will prevent apoptosis, programmed cell death occurring in cancer tissue. So there needs to be a balance, a homeostasis between this normal cell proliferation and programmed cell death. If that becomes an imbalance, where cells are turned on to divide rapidly and nothing to check by apoptosis, then we will have a chance of developing cancer. Proto-oncogenes become mutated to become oncogenes that support proliferation, mark proliferation, and the tumor suppressor genes that are normally turned on to control cell growth are turned off. And so that lacks then the support of apoptosis. I'll be showing you some pictures that will show this better, but multiple mutations are required for both the proto-oncogenes and to turn off the tumor suppressor genes. And this process of carcinogenesis can take up to 2 to 15 or more years before we see a cancer form. So in the process, what we get are decreased cell cycling time. Cells divide much more rapidly. They become immortalized. It means they're not restricted to the usual 50 divisions that occur. They become autonomous to the usual growth parameters. So in this, see, when we get the first mutation of a cell, we can get development which begins, and this cell just energetically gets sort of upgraded. If there's another mutation, that can cause an increase in number of cells, but these are actually normal appearing cells. And this, the pathologist will call this hyperplasia. But if there are continued mutations, we can then develop abnormal cells within this population. And if several mutations occur, then they can become independent. Now, this is called cancer in situ if it's not through this basement membrane, but if further mutations occur in those cells, then they can become an invasive cancer and actually invade into blood vessels and lymphatic vessels and go elsewhere in the body. So mutations, multiple. First we get cell proliferation, a number more of the DNA damaged genes causes a proto-oncogene to become an oncogene, and mutations further will produce cancer cells which eventually can become invasive. Just another way of looking at this, the initial initiation is by a first mutation, becomes an excited cell, initiated, and then progresses to a cancer cell. And in a three-dimensional view, the genes here are changed by several mutations and become damaged or changed and become autonomous as a cancer cell and become markedly able to divide. So as far as the cancer formation is concerned, you can see from this, and you can read this later, but multiple mutations are required. For women who have pap smears, they'll see these kinds of things listed on their pap smears. And tumor suppressor genes have to be turned off, and proto-oncogenes need to become oncogenes by mutation, and that will set up the response for invasion and autonomy. Other characteristics of cancer cells, not just listed in carcinogenesis, is that cells tend to turn off their mitochondria. They develop a low oxygen environment. They tend to increase the number of glucose-type receptors. So they tend to take on a lot of sugar. And with that, they are more highly metabolic, even though they tend to decrease some of the oxygen in those cells. So this allows for increased uptake of glucose for energy and allows for increased uptake of vitamin C. because vitamin C is similar, looks similar to those receptors and will allow increased amounts of vitamin C to get in the cancer cell. Other things that cancer cells do are produce human chorionic gonadotropin, which tends to hide the stem cells of the cancer tissue, and they start playing, they avoid the immune system by playing I am a fetus, so don't attack me. And this just lists, for people that are interested, these are some of the genes. P51 is important to be turned back on to help control cell division, and P53 needs to be in non-mutated form in order to progress to allow for cell suicide. Now, I don't know if I can do this. I'm doing this for Chad, basically, because I have 3 daughters, and he has several daughters. But if you look at the process of carcinogenesis, the cells go through several changes. And first, they become excited. And then they have a party because they have all these glucose receptors on them. They can have as much sugar as they want. And they get to put on this suit of armor called human chorionic gonadotropin and sort of become a super baby cell. With this, they can hide from the immune system, but it allows for lack of control of the tissue itself. So let's say a daughter cell goes out and does this and finds out, yes, this is fantastic. I get to do all these things. I get to party with the sugar, get to make all these daughter cells, and all of a sudden they find out they're doing all this work consistently, and all of a sudden the oxygen and the nutrients that they need to continue to do that are not any longer being able to be supplied. So with that, then they start to have problems. They have to compete, and it becomes a process where many times some of the cancer cells will die. So this daughter cell comes back to the mother and says, well, what can I do about this? I'd rather be a normal cell again. And the mother says, well, let's see about that. Maybe you need to join the YMCCA, meaning Y malignancy, use vitamin C for your CA. Okay. So what's the point? The point is that antioxidants tend to take these cells and turn off by stimulating the tumor suppressor genes, slow the proliferation down, then processes that are normally intact can help mend the DNA. And if a cell is beyond that, then actually antioxidants can help with making, they can also stimulate the apoptosis. Just a little bit about cell cycling. What happens is that we go through the phases of cell cycling very rapidly as a cancer cell. And I'm just going to go to the pictorials here. With this, interphase is where the cell actually is growing. It is making more DNA and getting ready so that it can do this division process. So this interphase can take a long time, and usually the division or mitosis, usually in 2 parts called by authors, or cytokinesis, where the actual cell divides. Mitosis is where the DNA divides. So with this, then, we start out with interphase, and we're getting prepared for division, whereas the centromeres and centrosomes go to different parts of the cell. The DNA goes from chromatin to chromosomes so that it can be ready to divide. During prometaphase, which happens in plant cells more than human cells as described, these chromosomes will line up with these spindle fibers, and once they line up to what's called metaphase, where it's right in the middle here, then they will divide and separate toward the poles of the cell and become 2 daughter cells by having further part of the cytoplasm dividing with this furrow right here, right where the metaphase plate was, and then we'll have 2 daughter cells. And in regular pictures of this, and it's not showing real well, This would be prometaphase. This would be the metaphase where you see the chromatin lining up. Anaphase, where these chromosomes are going to the opposite poles. And this was where that median furrow was. So with this, regularly we have 3 stop points where we can make sure that the cancer cells are not going to be dividing without being checked to make sure that their DNA is normal. We lose some of those checkpoints when we develop cancer cells, and the tumor suppressor genes are turned off and the oncogenes are in place. So what happens with this? The actual process of dividing is a traumatic incidence. And many times the probing of those spindle cells will cause a problem, spindle fibers that is, and help break up the chromosomes. And depending upon how those relocate, then we can get further errors in the chromosomes. And this is important because chemotherapy is able, even though it is able to take care of cancer cells through several mechanisms, one of the things it does is it causes its own resistance by producing some of these chromosomes breaks. And so it's one of the ways that cancer cells become resistant is to the chemotherapy itself by this method right here. So free radical formation from chemotherapy can slow cell cycling, we said that, and mitosis from chemotherapy resistance is produced by the slowing of the cell cycling. This is an important concept because as we administer antioxidants, if we slow the cell cycle, then we can hopefully prevent absence of apoptosis, and we can actually increase the sensitivity of the chemotherapy. So although free radicals from chemotherapy may induce apoptosis, too high levels cause mutation to the p53 gene, and which is required for producing apoptosis. So by giving the antioxidants, you actually preserve this process in the cancer cells itself. That's directly opposed to Dr. Selagnik's who says that we shouldn't be administering antioxidants to cancer patients because the free radicals are the things that promote the apoptosis, and that antioxidants would interfere with that. So this is one of the major differences in thought as far as why antioxidants can be used. Apoptosis appears to require several things. It has to have an intact p53, but it also requires an intact immune system. Both chemotherapy and radiation impair the function of the immune system, and antioxidants tend to support immune system function. They will increase the number of natural killer cells, their migration to areas where they need to do the work to attack the cancer cells, and that is one way. Plus, they also support the bone marrow to make stem cells for repair. This is in the cancer therapy drug manual. Different types of chemotherapy. We have several types. One is our alkylating agents. Cytoxin and ifosfamide are two of the most common. One of the major ways this causes damage to cells is by creating free radicals, although it has 3 or 4 other mechanisms that it can use. Antibiotics from Streptomyces, which is actually a fungus. Adriamycin is one of the more common ones that we hear about. Bleomycin is an older one. They also generate reactive oxygen species, which is by some people's definition of similar to a free radical, and they inhibit DNA synthesis this way. And the platinum drugs also will create free radicals which inhibit DNA synthesis. So, how am I doing on time here? Okay. But chemotherapy can block synthesis of DNA precursors. It can damage integrity of the DNA, can interfere with cell replication. It can separate strands of DNA or interfere with the function of the mitotic spindle. And the damaged DNA, this is where free radicals do most of their work. The other ones are by other mechanisms. So with radiation therapy, it produces its effect by direct cell damage to the DNA, causing cell death that way, preventing the cells from being able to divide. And it also creates free radicals within the cytoplasm, creating hydroxide and hydrogen ions, which can there go on and cause free radical damage to DNA and other cellular processes. So chemotherapy and radiation both create free radicals, which is one of their mechanisms for causing response in the cancer tissue. The theory behind giving chemotherapy is that we want to give as much as quickly as possible. And the reason for that is that we want to cause as much cancer cell death before we develop resistance to the chemotherapy. And so they have developed what's called a dose-dense chemotherapy. It's a very high-intensive way of giving the chemotherapy. But when doing this, resistance can develop due to mutation of the p53 tumor suppressor gene. So again, p53 is important to have apoptosis, but what is also important is an intact immune system, and research out of British Columbia shows that having mitochondria that are intact that can be turned on to aerobic ways of making energy molecules, those three things are part and parcel of being able to cause or have apoptosis. Antioxidant therapy tends to support all of those three things. Go through a short history of this. Although all the articles, this is the person who started it all, Glen Hyland, who developed the free radical theory of disease. And after Linus Pauling and Ewan Cameron had showed that they had had responses of cancer patients to vitamin C, Mayo Clinic sponsored these randomized controlled trials. And they did not find any benefit with using vitamin C as a therapy. They gave up to 10 grams orally. And so these, in the initial patients that had previous chemotherapy, and that was felt to be one of the reasons why they may not have been able to see response in this patient. But the next one they did, these patients had not had any previous chemotherapy, and they still didn't see benefit from vitamin C as a treatment. Linus Pauling and Cameron and Hugh Reardon would all agree, though, that the dose that was given wasn't even close to what would be required to see a typical response. And now with later research and with following we need to have a target level in our plasma of the vitamin C to gain responses. In this article, and this is one of the best review articles by Lamson and Brignall, and it reviews 180 articles regarding the use of chemotherapy and shows where there are positive responses, and I'll return to this later. Dr. Ralph Moss, PhD, who is also on the NIH board for use of alternative therapies in cancer, goes into marked detailing. He reviews about 480 articles, and his conclusion from this, he also used to be in research at the Sloan Kettering Memorial Hospital in the oncology division. He believes antioxidants improve the effectiveness of chemotherapy and radiation and decrease their side effects. Rudolf Salganik is the person from Chapel Hill. He's an MD, PhD, whose work would suggest that free radicals are necessary for inciting apoptosis in cancer cells, programmed cell death. And he recommended, even though his research showed that in a very specific species of mice, the ones who had brain tumors that were fed antioxidant deficient diets had greater response, than those that received antioxidants. They had nothing to do with chemotherapy with that study, but from this he suggested that antioxidants shouldn't be used. And he was a very vocal person, and the American Society of Cell Biologists took this, and this story was picked up also by other press releases and became one of the arguments for not recommending antioxidant therapy during the time of chemotherapy or radiation. So, and this is the article that rebuttals that, in his work at UCLA, Dr. Kenneth Conklin felt that it was the presence of too many free radicals that mutated the p53 and p21 genes, and therefore the presence of antioxidants to sort of subdue that allowed for cell cycling to continue at a pace where chemotherapy could be more active against the cancer tissue. And Gabriele Andre, she goes through a number of articles also, but comes to the point where she feels that antioxidants have not been proven to be safe, but she uses the same arguments about free radicals and antioxidants taking care of free radicals that it could interfere. And so this was one of the articles, though, a very good writer, but was influential in getting the Society of Clinical Oncologists, ASCO, to have a position paper written that stated that they should medical oncologists should tell their patients not to use antioxidants with their chemotherapy. So in rebuttal to this, Dr. Ralph Moss had this, and he reviewed that and showed where this article was selectively picking only negative things and was not looking at the full field of studies used for antioxidants combined with either chemotherapy or radiation. And he is probably the most read and most published of people in this regard as far as the articles written, and comes to the opposite conclusion. Dr. Charles Simone is an MD. He's both a radiation oncologist and a medical oncologist, and in his research has also come to the conclusion that chemotherapy and radiation have improved effects with use of antioxidants, and also has decrease in side effects. And Dr. Kedar Prasad has got at least 48 published articles, has done bench research both in tissue culture, in animal, and in humans, and with chemotherapy and radiation. He was the former director of the vitamin cancer research team at University of Colorado Medical School. And as far as basic research, he is one of the sort of founding fathers for saying that antioxidants should be used in treatments with patients receiving chemotherapy. And from his articles, the real teaching points are that normal cells and cancer cells differ in responses to antioxidants. Low-dose antioxidants shouldn't be used because in rare instances, only in tissue culture did they see cancer cells actually increasing in their growth. That has never been reproduced in human studies. But what the recommendation for this is that it is not a good idea to just take a multiple vitamin just before you start therapy, because that possibly could be a problem. What he recommends here is that you start your antioxidants before, keep them on during the time of your therapy, and for 6 to 12 months afterwards to get the best results. And again, he also found that high-dose antioxidants stimulate tumor suppressor genes that inhibit the cancer cell growth. He is a firm believer that you have to have a combination of antioxidants because they support themselves. C works better in aqueous solution. Vitamin E works better in lipid solution. And not all antioxidants produce the same effects. And there might be 5, 8 different types of a particular type of vitamin or antioxidant, and using the best one for that particular patient is important. So from this standpoint, cancer is not supposed to be considered a self-help disease. By that we mean it should be a patient's right to choose their therapy. We certainly would agree with that. But in order to gain information that will allow you to best use nutritional approaches, specifically antioxidants, along with chemotherapy and radiation, you need somebody who has really looked at this so they can guide the amounts and which types you need to use for your particular type of cancer. Antioxidants are found in higher concentrations in cancer cells than in normal cells, and even normally antioxidants can be higher in certain types of tissue. Pituitary adrenal gland, for instance, for vitamin C, concentrates vitamin C. But here, the other method, as far as certainly for vitamin C, is that the increased glucose-type receptors allow more vitamin C to get into cancer cells. And we've said this before, and antioxidants endogenously made, in other words, the dimutases in the N-acetylcysteine and glutathione, if they're administered exogenously, there have been a couple of reports where these do interfere with cisplatin chemotherapy. And so this is where some of the caution comes. You can't just use chemotherapy and antioxidants. You need to know where you can use them safely. However, administering glutathione by some investigators have shown marked decrease of side effects and improvement of response with that. And from Dr. Davis Lamson's notes, he has gone through these and shown where it can be used with cyclophosphamide. These are in animal studies and with increased and improved effects. When used with epirubicin, the antibiotics, this would also be like adriamycin. Vitamin A showed to decrease toxicity and improve survival. There are about 7 sets of these tables, but this will specifically show through a review of 180 articles with this where these are most effective. And I'll just go through some of these. Melatonin, I thought, was important just to hear about. Melatonin tends to stimulate the bone marrow, and it could be used, according to some investigators, Dr. Lassoni being one of them, that it shows that 20 milligrams of melatonin a day, which also helps with the sleep cycle, can support the bone marrow and blood counts during chemotherapy, as well as the Neupogens and Neulastas and Aranests, things that keep the red blood cells and white blood cells up during chemotherapy that are synthetic drugs. We went through this before, that the philosophy of chemotherapy is give as much as you can, as quick as you can. Radiation treatments do the same thing, but they have to take in consideration that the tissues that they're treating through and the sensitivities of those. So the amount you get per day, usually you don't get more than 5 treatments per week, and the total dose will be dependent upon what the cancer control total needs to be and what the tissue limits are as far as the normal tissues. Now I'd like to just present a case. This is a 50-year-old lady that developed a left breast cancer, but she had a lump in her left breast that she sort of ignored. But she was in higher stress time of her life. She had 4 kids at home, a single parent because her husband had had 2 tours of duty in Iraq, and she was dealing with a mother that had Alzheimer's. She was working full-time during all of this. The mammogram was positive, the biopsy was positive, and they did staging studies to show that there was no disease outside of this area. Physical examination did not sense any lymph nodes, but at the time of the surgery, the sentinel lymph node biopsy showed 1 lymph node positive, and the X-ray dissection showed 3 additional lymph nodes positive. So this patient was a stage 3. She had a tumor that was 2.5 centimeters in size. She had 4 lymph nodes involved, but no evidence of distant metastatic disease. She had an intermediate grade tumor. There was estrogen progesterone positive, but HER2 negative. The standard approach for this, after the surgery is done, is to suggest people have chemotherapy, adriamycin Cytoxan for 4 cycles, followed by Taxol for 4 cycles. The radiation therapy was given because of the 4 lymph nodes that were involved. It shows decreased local recurrence if you do that, and these were the recommended doses. And then medical oncology suggested, because this was estrogen positive, that person receive Arimidex or tamoxifen therapy for 5 years. So these are some of the side effects, obviously, of this. Change in breast contour, sometimes edema of the arm, and change in the range of motion. These are a list of side effects that can commonly occur. And from radiation, these are common changes. And So the patient, after having information not only that she read, but what many family members and friends will do, will send information about antioxidants and other nutritional therapies. So she asks her doctor, well, I'm going to be getting adriamycin. I know that's hard in my heart, and I'm going to be receiving Cytoxan. I know that sometimes causes hemorrhagic cystitis, bladder irritation with bleeding from the bladder. Is there anything I can do to help prevent this? Can I take any antioxidants? And medical oncologist said no, because he was following the position statement by the Society of Clinical Oncologists and said, but what we can do for you, we can have you take dexrazosan with the adriamycin to prevent cardiomyopathy that leads to congestive heart failure. And we can give you Mesna, which helps for the toxicity for hemorrhagic cystitis. Well, these are FDA approved for those, and they are actually antioxidants. So amifostine is also one that's widely used for head and neck cancer treatment. So you can see that even though the philosophy is that you're not supposed to be using antioxidants as far as the position statement is concerned, the medical oncology community commonly uses these, which are antioxidants. So it, from there. Now, for Hugh Reardon, as I mentioned, he was passionate about this, and in his 30 years has seen lots of people improve with antioxidant and good nutritional replacement therapy. So there are many studies out there showing increased effectiveness of chemotherapy and radiation while giving decreased toxicity to those therapies. And despite the fact that there are marked advances in the delivery of chemotherapy and radiation over the last 30 years, the initial tumor response, which the oncologists will tell you might be 30 to 80%, does not usually translate into any marked improvement in overall survival. And this is especially in adult solid tumors. And especially, it does not provide for maintenance of a good quality of life and functional and normal functional status. Unfortunately, the research studies and clinical studies are conflicting in these results. The in vitro results don't correlate, meaning the tissue culture studies don't correlate with what we see in animals, and not all the in-animal studies correlate with what we see in human studies. So what is important, though, is that chemotherapy works more than by just creating free radicals. It has other methods by which it's doing work, and many times it's the other processes that are creating the greatest effect. And it's also important to remember that antioxidants produce many effects that are not just related to quenching of free radicals, because antioxidants can work as pro-oxidants in cancer tissue. They can stimulate tumor suppressor genes, and that's not due to antioxidant activity. They maintain the immune system. They protect mitochondria function, and they help maintain P21 and P53, which are important for slowing cell cycle progression and allowing for apoptosis of the cancer tissue. So what we need are enlightened people who will be willing to combine antioxidants with standard therapy. And we do have a new generation of pioneers in this regard. One person who rotated through this institution, I'm told, is Dr. Driscoll from Kansas State University, who are looking at this. In her study, it's with ovarian carcinoma, standard chemotherapy, plus intravenous vitamin C. There are ongoing intents to do the same types of studies, not just ovarian, but a wide range of solid tumors at the Cancer Treatment Centers of America, University of Miami Medical School, and the MD Anderson Hospital. What turned the corner here was the National Institutes of Health Mark Levine study that showed vitamin C acted as a pro-oxidant in cancer tissue and acted as an antioxidant in normal tissue. Therefore, they were able to see improvement of effects from chemotherapy and have diminished side effects. So I look at this that we owe truly a debt of gratitude to people like Hugh Reardon in Linus Pauling's, the original pioneers of this work. But we also owe a debt of gratitude to the people that have done the studies that had opposite results. Because as Ben Franklin said, if we're all thinking the same, none of us are thinking. And we need to be doing research, and if questions come up, we need to try to resolve them. What we need is a balance. We can't just ignore the fact that antioxidants have had a predominance of improvement in cancer patients and when used with chemotherapy and radiation. We need to go forward and conduct those studies that will tell us better information. Thank you for your attention.
The preceding program was presented by the Center for the Improvement of Human Functioning International in the Bright Spot for Health Lunch and Lecture Series. To inquire about additional health-related information available on DVD, audio CD, VHS, or audio cassette, simply call 316-682-3100 or drop by 3100 North Hillside in Wichita, Kansas. To discover more about the center and what we have to offer, be sure and visit us on the web at www.brightspot.org.